Hello, Michael. Thanks for joining us today on my podcast. I'm sure you've listened to all of my podcasts up until now, but I haven't done one in some time because of various things going on in the world and in my life. But I'd been noticing that you've been doing lots of teaching. So you're absolutely all over the place on LinkedIn and teaching in North America, Europe. Is it Dubai as well involved? Middle East? Is that right?
Middle East, Asia, Northern Scandinavia. I haven't been to US, but it's coming this year.
Right.
I'm going to Qatar later in the spring.
Gotcha. So you're
South Korea, yeah.
Primarily, you're a clinician based in Denmark. That's right.
That's correct.
And you have a mixed practice of musculoskeletal and urology, which I think is why you do so much teaching for Storts, because of the mix of focus for musculoskeletal and for urology, right? So it'd be interesting to get some of your ideas today on those two energy sources in terms of mechanisms and how you see a sort of multimodal approach for treating some of these conditions. I know you're keen on sort of innovating, but using everything at your disposal. I know you've got the Storts EMTT as well. And you are a sonographer, which I now am proud to say I am after some hard work getting there. I am a novice compared to you, so I'm all about learning today. So just as a start point for everyone listening in, so give us just a resume of where you've come from, what's your career, and what are your interests today?
Well, I have a long background in the army before my work today, and I actually started with sports injuries, and by chance, I ended up buying Ultrasound and Shockwave. I actually started with laser, level 4 laser, and I was trying to fill the gaps. So I tried to find all the indications where you would fall behind between the chairs, where you couldn't get the help with normal rehab. So I only do Shockwave, laser, EMTT, and these kind of modalities today. So that's what I built my practice on. In the beginning, it was mainly the musculoskeletal. I actually started working with focus device and a radial, as many people are doing. I added the radial 1 year later after my first focus device, because I want to work with the fascia transmitters that Storts provided.
So you bought the focus first?
Because I knew that there was a way I wanted to go.
Right.
And then during 2019, I started working more and more on urology. I also took a sexology degree, education in Denmark last year. And today I'm doing around 60 to 70% of urology, mainly ED and Peyronies. And then the last 30-40% is more complex musculoskeletal. So the foundation is that I want to help people in the clinic or help to educate other people.
Okay.
My concept is quite simple. As you say, I use everything that's at my hands, no matter if it's radial focused. In the combination with ATT, that's really been a game changer. The level 4 laser supported by ultrasound. And even through I'm working for Storts and different dealers of Shockwave, what I'm saying now is on my own. That is my own opinion, so you can't put to account for that. But in my world, focus device, focus Shockwave, and ultrasound goes hand in hand. If you don't do the scan, you can't do a specific efficient treatment with focus device. If you work with the radial for basic muscle indications, relief of tension, trigger points, etc., then you can work with the radial without any problems, without doing ultrasound. But as soon as you pick up the handpiece for the focal device, then the other hand should be on the ultrasound scanner, and you need to do it. Otherwise, you need to have a guy or girl doing the scan telling you what to do with the device, because we want to be specific.
So a lot of people. Yeah, sorry, say that. Yeah, carry on.
And now I'm working with the Storts device, just as you. We also have the piezoelectric, we have the hydraulic systems, and they all deliver in different ways. So no matter what device you use, if you want to do specific treatment, you need to be very specific with your ultrasound scanning skills. especially if you're working with a piezo device, because the standoff difference is around 5 to 10 millimeters per standoff. So if you work with these devices and you don't do the scan, you're most likely not going to hit the target. With the stored electromagnetic technology, we have a wide focal zone, so you can be less of a experienced sonographer and still go on target. So that is really an important point, that do the scan and then do the treatment.
Yeah. I know one of the podcasts before this was with a physiotherapist who's a sonographer, and we agreed on that. He didn't have so much experience shockwave wise. So as you're saying, increasing or improving outcomes by targeting treatment is important. But the other thing that I've obviously found when you start picking up an ultrasound device by scanning is that you're also, number one, ruling out things that it wouldn't be good for, that you can't actually test for, seeing that there's a big bursa there, or number two, there's a big tear there, which actually your examination doesn't really bring to the fore. But it also allows, I think, the biggest thing that it's allowed me to do is really change my prognosis and management. That's not that painful. When you look at the scan, you go, there's a lot of tissue change in that tendon. That's pretty severe. I think you're definitely going to need 6-7 treatments, and it's going to be 5-6 months of rehab before you're back to normal. That's what it's given me. I think you do get some people, when I've talked about this with them, that certainly say that they would still go by reproduction of symptoms. I think that still has got some. I think that's still got some credibility. I think if you cross-reference ultrasound findings and also manage to reproduce their symptoms with focused, I think that probably is your gold standard. But like you say, you're still coming back to the idea that you're still missing information if you don't scan to some extent. And particularly for some tendons, some joint problems more than others. I get that. And when you're teaching across the world now, as you've had the benefit of doing, have you seen any differences in, a lot of what we do with Shockwave is still relatively anecdotal and experience-based and expert-led in terms of opinion, like yourself. Do you see across the world differences in people's, or in terms of groups of people using Shockwave? Have you discovered any differences between us, or are we all getting to some rounded view that everyone shares, do you think?
I think it's still religion in how you practice the different areas. In Europe, we have a very huge focus on the focus device and expanding and exploring new options. Not even, it doesn't really need to be a protocol, but if we know the basic science, the basic research, then we are more prone to try to find a solution. Where when I work in these, they're more keen on the specific protocols. They don't necessarily want to have all the studies presented, but they want to know that it's founded in some science. Now, I haven't had the pleasure in the US, but I'm quite sure that it's also founded in the science. Asia, also very focused on that there needs to be some research. My opinion from the Nordic countries is that we are very keen on everything having the gold standard. If we don't have a very specific study, then we can't treat it. And that is where I think we need to innovate ourselves during the next 5-10 years, because we have a lot of very nice basic research coming out from all over Europe and the world in general. So if we know these basic principles, we know that it stimulates the nerve, then we can use it for regulating pain. We don't need to have a specific study for the specific nerve to do the treatment. So I will enhance people to look more into the basic research instead of the very specific studies for shoulder or lateral epicondylitis. Because even when we look at the rehab, then we still have difficulty to define the right protocol, even though we've been doing it for the last 50 years. So there is some differences, but people are willing to learn. And that is also why Shockwave is getting more and more popular. And that's also where we need to be aware that we do the proper education for the people using it.
Sure. One of the things, because you're so involved in the education at the moment, my first podcast was 3 or 4 years ago, maybe even more actually. And with the mechanisms of what we thought Shockwave was doing, both radial and focused, and it was a little hazy at the time, even only 3 or 4 years ago. It was definitely, what we used to say is that we're creating an inflammatory event, and then that's creating a super healing response by the body. And then your body then goes forwards and, does its magic. And obviously now we have focused and we have radial, and some of the concepts behind the mechanisms have changed a bit. So, and it does get very complicated. So could you just summarize very neatly about what you think the main things that radial does and the main things that focus does now, do we think?
When I do my teaching, I always divide it. So with the radial, we work with the tissue. It's a musculoskeletal system. It's muscles. It's mechanical input to the tissue. When we work with the focus device, we work with the cells and everything in between. So for me, one of the most important factors in the focus device is mechanical suction. It's a very complex process, but that is basically rebooting the communication between the cells and restarting the healing process. The latest research shows that we maybe get the same effect from the radial device, but it's only one study where they start looking into it. In the future, we would most likely see similar effects from both devices, but right now we know that for science, we work with the cells with the focus device. So we have the mechanical construction, we have the formation of different growth factors, we have the stimulation of nerves and the pain regulating hormones. With the radial, we have the ability to release tension in the tissue. We have the ability to create movement across the joints, especially if we use the fascia transmitters. So if you want to work general and peel the outer layers of the onion, then you start with the radial. And then when we're gonna go to the core and the more specific, then we work with the focus device. And the best combination is the two technologies together. So tissue, muscles, tension, pain regarding training overuse, then we work with the radial. Everything complex, tendons, bones, chronic pain, things where we've been having a long injury process, then we work with the focus device. And then of course urology, that is my big interest right now. For the erectile dysfunction, the Peyronies disease, we're gonna work with the focus device. That is why we have 99% of the studies. I think there's one or two on radial, not very promising. Even though I know that in the US, the radial device is quite commonly used for erectile dysfunction. But when you work with it yourself, you can try to imagine doing radial on your penis. I did it on a client today that wanted to know the difference.
Oh, really?
And after 5 pulses, he asked me to go back to the focus device.
I think that, to be fair, I think they use lidocaine as a cream to try and numb the penis before they put that on. And then they think, well, for the amount of money the client pays for that treatment in America, you think they could afford a focus device, quite frankly. But it just does seem to be a difference in cultures almost, that they think that radial is the thing and the focus.
Then the next thing is that in the beginning, when we used the focus device back in the 80s and the 90s, that is before I was even going to school, they use anesthetic. And we now seen very nice studies over the last 40 years showing that if you use anesthetics in combination with shockwave, you have a lesser significant effect. So why should we numb the tissue?
Yeah, right. Yeah. And that's goes back to what you were saying, because there's obviously having an impact on the cellular mechanisms when you have anesthesia, and that's interrupting what the focus is doing, which is to work at a cellular level. So just going back to the urology aspect. So when I know that you're keen on the scanning, and we're going to have to try and get you over to the UK, do some teaching with us, because, scanning things like Peyronies and trying targeting treatment, it's very difficult to the untrained eye. And yourself, when you're training with sonography, it's less about the amazing machine you're using. It's more about training these and knowing what's normal and what's abnormal. So in terms of scanning for things like Peyronies, what are you looking for in terms of guiding treatment and so on and so forth? What's your experience with the sonography of Peyronies?
The first thing with that part is that there's no courses for it. So I had to find some books and a lot of different studies and then just start scanning. So I've been scanning it for more than 3 years now. And in the beginning, I was also, we all know the different pictures on Google and from the studies that you have the hard formation. But then I started seeing these guys coming with 90-degree curvation. There was no plaque. then I found some studies looking at the tunica of the penis, that it could be swollen, it could be calcified in that area. So you really need to know the normal anatomy. And then I look for if there's any visible hard plaques, if there's any swelling of the tunica or fibrotic tissue. And it's difficult to see if you don't have a really high quality ultrasound device. I have 2 devices in the clinic. I have a top notch from Sonography, the new LX. There's only 1 or 2 in Denmark for the moment, and the only one operational is in my clinic. And then I have a small portable device, and the guys supplying me in Denmark, Sigma, asked me if you could use the small portable device for doing the scan. And I tried it last week, and I haven't been doing it because it hasn't been relevant, but even though it's a very nice device, you can see some of the things. You can see if there's a hard plaque, but you can't see all these small details. So even though you need to use the eyes, you also need to have a high quality device to see these very small differences in the penis. It's the same if you go to the scan of the arteries with ED. You also need to have a very good device to find this artery that's not more than 1 millimeter in diameter. So the ultrasound scanner is actually quite important in the urology scan compared to the musculoskeletal. So I have these 3 things I'm looking for, and that is defining what kind of intensity and what kind of protocol I'm using for the specific treatments. Of course, I follow the normal guidelines. It's going between 2,000 to 4,000 pulses with the focus device for Peyronies. And as you most likely know, I've been experimenting with the C-Actor handpiece for the last 8-9 months. And I'm working with energy on 1.24 when I work with the hard plaque. Because the latest studies coming out from Lars Lund in Odense is that we've been using too little energy. I had a talk with him 1.5 years ago at the university hospital, and he did a study comparing Shockwave for Peyronies disease with a vacuum device and he could see that you are benefiting more if you use the vacuum device in combination with the Shockwave treatment. But the new thing was he had reduced the pulses to 2,000 and doing 0.55 in intensity. So I had a talk with the STORT people and Professor Rasweiler in Germany last year, or in Switzerland last year. And we talked about this need of intensity. It's the same with the study from Bruce that also evaluated 350 cases of ED, Peyronies disease, and concludes that most of his studies has been markedly underpowered. So therefore, I started trying to work with high intensity, and with this anecdotic approach, it seems like I'm getting more effect with the high intensity for the hard plaques.
Patients are tolerating 1.24?
Yeah, they are. It's not a problem. Again, we need to look into the depth of delivering.
2,000, 3,000 shocks?
I've been doing 3,000 pulses, and I'm trying to, now I'm starting to play around with, I do less, perhaps 2,500. So that is something I'm trying right now, but also depending how big is the plaque, what is the density of it. If I'm working with the ossified tunica of the penis, then I'm doing 0.78 intensity, delivering to the surface of the penis and hit the calcified area. And with these clients, I can see results within 4 to 8 weeks. And normally I do 6 treatments. And I always say it's a bonus if you experience anything during the 6 treatments, but the result will come after 6 to 12 months. But starting working with this high intensity, I could actually see that they're improving faster, but they also do the vacuum device. Do the vacuum device, bending exercises, 20 minutes every day for 6 months. I also combine it with the EMTT, doing 2,000 to 3,000 pulses, depending on how I build the treatment, what's mostly necessary. And that is also why that for ED, at some extent, you can do it without doing the scan. But if you want to be specific about Peyronies, Peyronies is not just Peyronies. There's 3-4 main indicators that can be the reason of the problem. You also need to work very specific on the plaque. So I have the holding arm from Storz, so I can fixate the handpiece on the specific point of the penis, laying in the penis lip, so everything is stable. And that is why you need to do the scan, because otherwise you're not hitting the right structure. If it's just the tunica calcified, then you can do it general like you do with the ED protocol.
Mm-hmm.
But if you want this very specific plaque that's perhaps 2 times 2 millimeters, then you need to be on point. And the next thing is that even though you can feel something, you can't see what it is. So I have clients coming in saying, yeah, I have a big nump in the penis. I can feel it like a pee. And I say, yeah, it's fine, but now I'm gonna do it again, and then we'll see what it is. Because when the tunica is less flexible, then it can be difficult to get friction. It can be difficult to dilate. So we need to work with these very specific structures, just like if we work with an Achilles tendon. It's really complex to work with Peyronies if you don't do the scan, because you don't know what you're shooting into.
I suppose the answer to all of that would be, in the perfect world, which I think I've listened to you on a few of your podcasts that you've done, is that we'd have urologists and specialist sonographers working with urologists all communicating with us, and everything would be lovely. But I mean, you know yourself from dealing with urologists is that it's take the medication or it's ultimately the full operation and nothing in between. If it's painful Peyronies, we do get referrals from urologists saying that that'll help. But for changing the curvature or doing anything else, they're still pretty resistant about any non-invasive treatments. I think they inject verapamil a few times, see if that works, and then we'll cut you open. And then that's obviously when patients seek our help, because they say, look, I do understand it might not work, but I'm willing to give it a go, because anything other than the operation sounds good to me. But it does seem to be that there's a big gap not in the market. It's a big gap in how these patients are cared for, because they literally get that really end of a spectrum option from the urologist, and then they come and see us, and we're doing our best. I mean, you're at the top end of that tree, if you like, doing the scanning and everything else. And I'm going to start doing the scanning and try my best to maximize the treatment outcomes. But and hopefully I will. But there doesn't seem to be anything in the middle, and no communication between any of the medicinal or medical world on this.
And the biggest problem is that the conventional treatment of Peyronies is wait and see for 6 to 18 months until it burns out. Yeah. We know from Shockwave and the research that the biggest window of opportunity is within the first stages. 18 months. Yeah. And I've been lucky to have guys coming in a few weeks after they start noticing it. And we've been doing some tremendous good results where we have basically no curvature, perhaps 10 degrees. That's good after 6 months. I've also seen guys where they just figure it out and they already have a plaque that's 2 times 1 centimeters. So we really need to get them in the early stage. In Denmark, most urologists doesn't work with Shockwave. We have Lars in Ultrasound that's really the pioneer also with the research. He has a waiting list on about a year just to have the first exam. So a lot of people is going private. In Sweden and Norway, they don't have the options. So due to my work with Storz, I met some of the urologists in Sweden. So in the southern part of Sweden, urologists is actually starting to send their clients to Copenhagen. So we need to work with the communication between the different specialists. If you've seen the videos I've been doing with the 2 Norwegian doctors the last few weeks, it's also about working together instead of just putting everything in columns, because we need to find a holistic way to work with the specific client. And that's also why that Shockwave is a part of solution, but we also need to do PD5 inhibitors. We need to do vacuum exercise. We need to do exercise. We need to eat healthy to get the best benefit from the treatment. So my goal is really to try to cope with most of these things within my scope of field.
Yeah.
And if everyone is doing that, then we can do some really good solutions. And regarding operations, I've been seeing 15 guys now that's been having surgery already with a negative outcome. They've been having an initial good result, and then after
this is
3 to 6 months,
surgery for Peyronies.
Yeah.
Yep.
Where they then get curvature again, or they even have pain afterwards. So that is also a problem. Today I had a client coming in having a penile implant that has been removed due to infection. And I did the scan. You can really see the damage and the scar tissue in the penis. We're gonna do 12 treatments over the next 3 months. It's not the typical ED or PD protocol, but I just want to see, can we do anything to tissue that's that damaged with the Shockwave and the EMPT? And the guy is actually an orthopedic surgeon, so he's really keen on, let's just do something, even if we don't know if it will help.
Yeah.
So maybe if lucky, we can do the scan on him someday. He wants to travel. So the key message is really that you work with this, then do the scan.
Yeah. And I have a feeling, I think you might be lecturing over in the UK this year at some point. Are you coming over to see us?
Yeah, in October there's some conference.
The Innovations Conference. It's by the UK distributor. We have once a year, so that would be great. I think we're going to try and grab you for some extra time to talk about some scanning and things like that. But I'll put the links to the last 2 podcasts that you've done, which are excellent. One was with a hematologist, wasn't it? And the other one with the cardiologist.
Yeah.
And people are sometimes surprised to hear that we have to, because obviously when they start to understand ED and they buy a focus device, they come and do some training with us, and we're trying to say to them, look, you can't take these patients on unless you understand that it's a cardiovascular disease, ED in essence, and you're going to have to go back to the drawing board of your knowledge that we learned at university and totally redo it. You've got to know their triglycerides, you've got to know whether they're a diabetic risk, whether they've got this obesity problem and so forth. But they were 2 great guests you had on your podcast, weren't they? Because they would, as all the best people are, they're really humble, and the way they delivered their knowledge was superb, wasn't it? And unless you tackle that stuff, we do know that patients come to us, don't they? And they just want an easy fix. And then you have, once you educate them, you go, this is not an easy fix. My machine helps it, but you've got to do your stuff. And if you don't do your stuff, then I sort of say to them, look, you could be wasting your money here. But there you go. You've given.
I tell my clients that if they don't work with the lifestyle, all the other things, then we can do the Shockwave, but it won't do the difference in the long run. And it's quite nice that you're capable of doing it. Well, I don't need to treat you.
Yeah.
Instead of being forced to take every treatment you want. And the 2 guys from Norway is really great. And I'm going to see them in 3 weeks, I think 4 weeks, when I'm going to Stockholm and Oslo for some educational activities.
We lost some Wi-Fi there. Repeat what you just said. Those guys that you're meeting up with, who were they?
Yeah, the 2 doctors I did the talks with, the hematologist and the cardiologist.
Gotcha.
I'm meeting them in 3 weeks when I have some educational activity with starts in Stockholm and Oslo. They are living in Oslo, so we're gonna have some breakfast and talk about what kind of projects we're gonna do, because they want to have more attention to the ED and Peyronies in Norway, and they're not urologists, but they see these clients every day. So I might gonna do a bit more work up there as well.
Oh, good for you. Good for you. Okay, I think that sort of covers most things. Is there anything else? I mean, in terms from your point of view in education, are there any key messages you want to get across in terms of? I mean, we have a lot of listeners from North America and Canada. Well, North America is Canada, obviously, and the United States, and their types of protocols that they use. I mean, I'm trying to think of anything that they often ask me. Sometimes they get hold of me on email and ask me questions. Is there anything that you'd like to put across in terms of Shockwave and mechanisms, and anything else that you think pertinent for the audience?
I will say with the focus, you do the scan. With the radial, you need to have a full set of transmitters, because that is really where you can limit yourself if you're only working with 1 or 2 standard transmitters. That's really going to be a limitation of what you can achieve with the radial device. And then, as you also been told when you started doing your sonographer training, it takes 2 years to be a good sonographer. You need to scan every day. You need to do lots of scan. And it's the same with Shockwave. It's a skill. So the more treatments you do, the more specific and specialized you can work. So start with the basic indication and work forward. So instead of having 10 guys in the clinic working with Shockwave, then have 3 guys doing it full time, doing nothing else. They're going to be really, really skilled. And that will just lift the level of the clinic as a whole. Instead of you having this device be dragged back and forward by all the people using it once a day, doesn't really make sense. And especially not with the focus device. And that's all what is with a lot of the guys in the UK. You do the scan, you do the focus, and everything else is outsourced to other people in the clinics. So really work with it every day. Have full range of transmitters, look into the fascial system and the way that we can use the radial device for that, because that is quite amazing. You can, in under a minute, create improved range of motion in the entire shoulder chain or the chain of the leg without doing anything, basically. And then you can start working with the standard transmitters. So really just work a lot of hours. Take it in as the one thing you do, and then you get the level. That is what I've been doing since 2016. Only working with these very few technologies, have a very specific clinic. It's only for Shockwave, so you're also attracting these clients. So be specific and then be innovative. Try different things. Try it on yourself and just keep reading different studies so you know the basic research, and then apply it into the practical setting, because there's a difference between the university setting, the hospital setting, where you do all the nice studies, and then the real world with real people where you can do more than one thing.
Yeah.
So take the perspective of all the options there is, and then just apply it and see what happens. There's nothing dangerous in Shockwave. It's non-invasive.
Yeah.
And if you've been having a proper training, you can't do any wrongs, as long as you check off the red flags: pregnancy, cancer, don't work on the brain, etc. So just get out there and work hard.
Perfect. I think I just lost you at the end, but I think we got that because my Wi-Fi's, I thought your Wi-Fi's dropping out. I think that's a good point to end, which is that, you know, the safety profile of Shockwave has massively improved over the last 3 or 4 years. Now we know so much more about it. We know when there's no damage, but really it's experiential, isn't it? And just trying to just get it on to tissues and then just see what comes back, which is often just amazing, isn't it, really? I mean, I know we're biased, but I've been using it over 10 years and it never ceases to amaze me. There'll be once a week where I'll be like, wow, you're better already. I never thought that was going to happen, you know, but you got to be doing it lots. And I sometimes, you know, I sort of get a bit lost in the fact that obviously I've got a lot of experience now, but, you know, if you only do it once or twice, I can see that that's just not to get you any good results. But that's a great time to finish. I think we're both going to go and have tea after a long day that we've already discussed. So thank you very much for coming on our podcast. And
thank you for having me.
We'll put links to some of those things you mentioned earlier down below after this, especially your podcasts. And thanks very much again. Cheers, Michael.
Thank you. Have a nice evening.
Thanks a lot, Michael.
Thank you.
Cheers.
Bye.
Bye-bye.